So we said that you have your this is our C spine, this is our T spine, this is our L spine, this is our sacrum, this is our heart. And you did say that the area of interest is the lumbar when you're doing the spinal. And we did also explain that with the L spine, so you have got your L1, L2, L3, 1, 2, 3, L4. And we did say that what you're looking for is somewhere between L3 and L4. So this is 1, 2, 3, 4, 5. And we said that there's a way of checking the level where you are using your posterior superior iliac spine. You draw an imaginary line. It's supposed to be at the tip like that. So it's supposed to go through your L4, and this is where you want to go. You want this space and this space. Right. I know in the exams they like to ask, especially for students, they like to ask what layers do you go through as you push in your needle there. And the first layer that you're gonna go through is the skin. The other one, the next one will be your adipose or your subcutaneous. So this is 1, this is 2, this is 3. The next layer would be your supra spinous ligament. The fourth one would be your inter spinous ligament. Fifth one would be your ligamentum flavum. Then the next thing that you're gonna encounter is your dura. Then you go through your subdural space, and then you meet your arachnoid. So these are the structures that you go through as you push in the needle. The most resistant one is this one. It feels like a rubber. After going through your ligamentum flavum, your force should be really controlled, because the next thing you're gonna be here. Just to complete the anatomy. So we said that the reason why we come here is because we know that, and we've been taught that the spinal cord runs down up to the lower border. In other patient, it can still extend to the upper border of L2. That's why we run away and go to L3. So this would be your where it terminates. They call it the conus medullaris. And from there, now you get those fibers that keep going, which is your coda equina. those fibers. But those fibers, like I said, you still have the membranes that came down with the spinal cord, and and inside there you still have got the CSF. Still have got the CSF. It's not to complete anatomy. Now let's talk about the indications, the contraindications rather. We said that in terms of the indications, we did speak about this. Like we did say that when you've got surgery that is going to be done in the lower limbs, when you've got surgery that is going to be done in the lower abdomen, when you've got surgery that is going to be done in the perineum, right? Lower abdomen, for instance, C-section. What else am I missing there? Yeah, surgery in the pelvis. This is when you can consider doing a spinal anesthesia. But what if now you've got what are the contraindications? Contraindications. Contraindications are divided into two. There is what they call absolute and relative. Absolute contraindication is when the patient refuses, and we've had this last week. The patient refused, and we had to do a GA. Patient refusal, infection on the site of interest, which is L3, L4, or L4 and 5. A patient who has got some coagulopathies, what other contraindications that are absolute? So guys, this is just before I go on, this is a very, that's the reason why I'm coming back to this, is because this is a very high yield for students. These layers, you have to know them. They can ask you to list them, or they can do they can ask in the form of Dropbox. See, Dropbox. And yeah, so it's very important, and it's very important to know what kind of operations would you want to do. I mean, you cannot say you're gonna do a spinal when the patient's gonna do a neck surgery, they're gonna do a head or an upper limb surgery or an upper chest. It wouldn't make sense to do a spinal anesthesia there. So also the contraindications, they are very important. They are very important, because when there's contraindication, it means that if you go on, you might just find yourself in trouble. So yeah. So the other absolute contraindications is patient with a fixed cut output, as in mitral stenosis, aortic stenosis. And why is that? And also, patient has got an increased intracranial pressure, and yeah, I think that's about it. So the thing is, when you've got a fixed cardiac output, when you become hypotensive from the spinal, it means the body will not be able to have reserves. The body will not be able to manipulate the blood pressure to suit or to compensate. Let me put it that way. To compensate. So that's one of the problems. So it's mitral stenosis and aortic stenosis, fixed cardiac output, fixed cardiac output. So what is relative? So obviously, when you've got a patient who's got an infection in the site, it means pushing the needle through that infection will deposit bacteria into the CSF, and that is in the brain already. And also coagulopathies, so you stand a risk of a patient bleeding there, and they might bleed into the space there. And there are patients that have bled so much that they become paralyzed according to literature. Okay, and then relative contraindications include uncooperative patient, uncooperative patient, a patient with sepsis, uncooperative patient, a patient with sepsis. Why I think I'm remembering now? Because of sepsis. I remember now. A patient who's got severe hypotension is a contraindication. Remember, if you go in theater and you already have hypotension, and you're gonna be giving drugs that will cause, spinal does cause hypotension, so it means this patient is gonna get into shock. There's no other way. Once you get into shock, we get into organ hypoperfusion, and those organs, they die. You get multi-organ failure. So you want to resuscitate this patient before you take them in, and yeah, you want to resuscitate them. And the patient who has got severe back deformity. We had a patient sometime this past week. This patient had a scoliosis, kyphoscoliosis. The nice thing about her is that the part where we had to inject was fine. So the kyphoscoliosis was only starting above, somewhere as you exit L, somewhere around L2, L1, going into the thorax. That's where it was severe in the thorax. So we could still do it. So yeah. Okay, another thing is pre-existing neurological deficit. Meaning someone who's pregnant, they had polio, they can still have a spinal, for instance. I need to start using my camera, guys. I have a camera that is just sitting there because I ran out of space. So what we are saying here is that, just a summary, when you want to give a local anesthetic, the lambda is the level that you're concerned about. So even if a patient has got sepsis in the T-spine, in the C-spine, you can still do a lumbar puncture, but you don't want it to be in the L-spine, especially around your L3, L4. So what I was saying is, we must know the indications of a spinal, lower limb surgery, lower abdominal surgery, perineum, and pelvis. And then the layers that you go through is your skin, your adipose, your supraspinous ligament, your interspinous ligament, ligamentum flavum, dura mater, arachnoid matter, and then you are in the space. And like I said, it's the most resistant. It feels like rubber. And also, contraindications are divided into absolute and relative. So try by all means, guys, not to, when you answer questions, try by all means not to mix this up. Know what is absolute and know what is relative. Because if you say someone who's uncooperative is a contraindication, it's relative. It's not it's a relative contraindication. Someone's got sepsis, it's relative. When it's relative, it means that it's not an absolute. You can go, you can negotiate there, you can do something, and it's not like if they've got that. An uncooperative patient, they can come in uncooperative and then later on they become cooperative because you spoke to them and all of that. So on the next video, we're going to be talking about now the drugs that I used.